I'm Raj Makkar from Los Angeles, and I want to thank Samin and other course directors for inviting me to talk at the symposium, and I want to wish everyone good health. Um, in terms of bicuspid morphology, 4DCT is an excellent tool for phenotyping. As you can see in this particular slide, that these are all different bicuspid aortic valves, but they have different implications in terms of planning the procedure or whether in terms of choosing whether you would actually send this particular patient for surgery or for transcatheter aortic valve replacement. So what matters most to a TAVR implanter is the number of commissures more than the number of cusps, the degree of calcification, the presence of raphe, if it is calcified especially, correct sizing, which is affected by all of the above features, in fact, to minimize not only root injury, but also to reduce paravalvular aortic regurgitation. Now, despite multiple series, including this very classic manuscript by Dr. Roberts, which suggests that though the prevalence of bicuspid aortic valve in patients undergoing isolated AVR is almost 50%, when you look at number of registries, such as the TVT registry, only 3 to 7% of the TAVRs are actually being done for bicuspid aortic stenosis. So as we talk about the data for TAVR and bicuspid aortic stenosis, I think we should keep this in mind that TAVR is therefore being used selectively in bicuspid AS, and the data should be interpreted accordingly. So I thought I would start off by describing what is going on in our lab. So here are some case examples. So this is a 64-year-old gentleman with symptomatic bicuspid aortic stenosis. What I want to point out here is the fact that the left main coronary artery here was originating at 7.9 a millimeter square, and that was clearly an anatomical exclusion we felt, and this patient was sent for surgery. Here's another patient who's 53-year-old physician with severe aortic stenosis. The showstopper for TAVR here was, in fact, the aortopathy. If you look at the aortic size, it was more than 4.5 centimeters. And in addition, the calcium was actually quite significant. So clearly, this is a patient that we sent for surgery as well. Here is a patient who's 80 years old, and in fact, if you look at it, there is not one but two calcified raphe here, but they're not very severely calcified. And the left main origin was borderline, but the sinuses were large. We went ahead and treated this patient with balloon expandable TAVR, and he did really well. And this is his echo, the following day with no paravalvular leak. Here is a patient who's 65 years old. The gradient is 50 millimeters of mercury. And if you can see, there's actually some calcification in the LVOT. But the coronaries were very high. So we, in fact, thought that not only is this a good case for TAVR, but also a repeat TAVR in the future, which may be required given that he's only 65 years of age. There were other social issues with this patient, and we, in fact, decided as a heart team that TAVR was a suitable treatment for him, and we treated him with the Sapien 3 valve here, as you can in fact see, a Sapien Ultra valve, and this is the echo on the following day with no paravalvular leak. And to get a little bit more controversial here, in fact, is a 69-year-old patient who has aortic stenosis. Once again, the left main height was 9.9, but the sinuses were quite large. And this patient wanted a TAVR, and we did go ahead and offer a TAVR to this particular patient. As you can see, that the valve is actually quite ways away from the ostium of the left main. And despite the fact that we protected the left main ostium, we did not have to use a stent. We feel that this patient may also be, in future, a reasonable candidate for TAVR and TAVR down the road. This is the echo that actually showed mild paravalvular leak. So what is the data? I think I want to start off with this TVT registry data in almost 2,700 bicuspid aortic stenosis with the average age of 74 and STS of 4.9. And After propensity matching, what we found was that the bicuspid aortic stenosis TAVR outcomes were actually quite good. Though the conversion to surgery was more frequent in bicuspid aortic stenosis, it was still less than 1%. And the annulus rupture occurred in 0.3%. The need for second valve was in 0.4%. If you look at 30-day outcomes, the all-cause mortality was similar between bicuspid and tricuspid aortic stenosis. The stroke rates were somewhat higher in patients with bicuspid aortic stenosis, 2.4% compared to 1.6%, and the pacemaker rates were 9.1%. One-year mortality was similar, if anything, a little bit lower in patients with bicuspid aortic stenosis. And similarly, the stroke rates actually were very similar at 1 year. The paravalvular leak rates were also not different between bicuspid and tricuspid aortic stenosis, but I think it is important to understand these are site-reported without core lab adjudication. Similarly, mean gradients and aortic valve areas were also similar between bicuspid and tricuspid aortic stenosis. Looking at the TVT data, we do get a big picture, but I think it's important to be granular. And my associate, Sang-Han Yoon, in fact, assembled more than 1,000 CT scans from over 24 sites globally, and looked at the anatomical features. The type 0 bicuspid aortic valve was present in 10%, and the rest of the 90% of the patients actually had type 1 bicuspid aortic valve, and half of these actually had calcified raphe. The STS score of these 1,000 patients was 3.7. Sapien was used in 70% of these patients, with Evolut Pro being the second most commonly used valve in 18% of patients. The 30-day mortality here was 2%, and the stroke was 2.4%. But more importantly, looking at all of these different phenotypes, CT phenotypes, what Sang-Han showed was that the combination of calcified raphe plus excessive leaflet calcium, in fact, produced worse outcomes in terms of aortic root injury, in terms of more than moderate paravalvular leak, and also in terms of 30-day mortality. So here is the central illustration of this paper that was recently published in JACC, and what it shows is that the combination in the upper curve of the combined calcified raphe and excessive calcium was one that was associated with the worst outcomes compared to patients who had none of these features. So what should we do? And how when there are patients that need TAVR, and in fact they have high risk anatomical features such as this one. You can see there is excessive calcium, there is calcified raphe, and this is clearly somebody, a patient where if you don't be careful, would be prone to aortic root injury. So here are the this is the area 497, and in this particular case, once again, we used a 26 millimeter valve, but in fact with a lower volume, in fact -3 cc's. So I think these things are important as we do these procedures, and you can see how the calcium and how it actually causes the recoil, which necessitated, in fact, an additional dilatation, though with a smaller, not with more volume, but with the same volume. This is the aortic root angiography. So it was feasible and possible to do this high-risk patient because the clinical situation demanded so, but I think one has to be careful. So what are the other data? So I think the other important data are the PARTNER 3 bicuspid registry and continued access program. I think if you look at these are data from 30 sites, a total of 237 patients were presented to the committee. 173 patients were enrolled in both registries. And almost 1/3 of these patients actually were excluded because of anatomical features. You can see that the age is 68 and 71 years, and the STS score here was 1.4 and 1.5 in registry and continued access program. I think the important thing to stress here is that there was zero mortality. If you look at in-hospital, zero mortality. And if you look at other complications as well, they were actually 0%. So I think these are excellent data for the use of balloon expandable stent in bicuspid aortic stenosis, with the caveat that, of course, as you must know, that 1/3 of these patients were excluded based on anatomical features. If you look at the 30-day outcomes, once again, all-cause death was 0%, and at 1 year, the all-cause death was 1.4%. One has to say that these are outstanding data. And these are some of the other secondary endpoints. I think the important thing to point out is the pacemaker rate was 9.9% in registry and 5.1% in the continued access program. So some learning there. Now, paravalvular aortic regurgitation rates, there was no case with moderate or severe paravalvular regurgitation rates. And the rates for mild PVL were about 27%. So similar data exist, not as large, but, also for the Evolut Pro in bicuspid aortic stenosis. So I think if you look at the outcomes here, these are data presented by John Forrest. You can see that the 30-day mortality was 3%, and this was significantly better than the previous experience with the core valve, and the stroke rates were 5.6%. Now, going to the more recent experience, not from the TBT registry, but from a properly controlled prospective multi-center registry sponsored by Medtronic, where once again the key exclusion was less than 60 years of age. 222 patients were screened, and 149 patients actually ended up getting the valve. And most of these patients, like all series, were type 1 bicuspid aortic stenosis, 90%. And the average age was 70, and the STS score was 1.4. Once again, if you look at the all-cause mortality, it was 0.7% at 30 days. So I think these are excellent data. If you look at the stroke rates disabling, also less than 1.4%. The valve hemodynamics were excellent, and also there were no cases of moderate or severe aortic valve regurgitation. So in ending my talk, I want to first talk a little bit about what are the practical considerations. I think it is important to be careful about unfavorable anatomic features on CT. So I think it's important to be careful when there are patients with excessive calcium, and patients with calcified raphe, and combination particularly of these features. Some degree of undersizing is appropriate, but we still believe in annular sizing and not in supraannular sizing. Position is harder than positioning the valve may be a little bit harder than the tricuspid valve. We tend to do these cases with TEE due to higher rates. There are higher rates of AI and aortic root injury, and I think TEE can be helpful in detecting these and taking care of these. Pre-dilatation is a good idea, and I think it is important to keep that in mind, and post-dilatation may be required as well. So in summary, the favorable outcomes, there are favorable outcomes with TAVR in carefully selected patients with the SAPIEN and Evolut in real-life TBT and sponsored prospective registries. CT phenotyping is important in patient selection and procedure planning, while bicuspid TAVR is justifiable in intermediate and higher surgical risk patients. Higher risk anatomical features such as extreme calcium, heavily calcified raphe, concomitant aortopathy should prompt consideration for surgical AVR in low risk patients. Randomized trials and prospective registries, especially in patients with lower surgical risk, are needed. Thank you.